Hello, everyone, and welcome back to Teleclass Education. My name is Paul Weber, and on behalf of Professor Syed Sattar, the co-founder of this initiative, I am pleased to introduce today's teleclass lecture, Cleaning the Gray Zones of Hospitals. An article with that same title was published in the American Journal of Infection Control last year, and I liked it so much that I invited the lead author to present this information as a teleclass. The author was, and still is, Dr. Makada Semrat. Dr. Semrat is, as you can see on the title slide, an assistant professor at McGill University and infection control officer at St. Mary's Hospital in Montreal. Her research focuses on hospital-associated infections in Africa and in Canada, with an emphasis on specific infection control measures that will improve the quality of care and patient safety. Something I didn't know about Dr. Semrat until researching these opening comments is that she developed an international program for training doctors in Ethiopia to specialize in the field of infectious diseases. And I find it shocking that there were only 2 such specialists in the entire country of millions of people. And this is when she first started this program. And fully half of the deaths in that country were caused by infectious diseases. It is my absolute delight to present Dr. Makada Semrat and her lecture, Cleaning the Gray Zones of Hospitals. Makada, the floor is yours.
Thank you very much, Paul. Thank you. Hello, everybody. I'm delighted to tele-meet you. I'm very impressed with the amount of research that Paul has done in order to introduce me, and hopefully he'll invite me again to talk about Ethiopia at another teleclass sometime in the future. So for today, as was mentioned, the topic is cleaning the gray zones of hospitals. I noticed that there have been several very excellent presentations on environmental cleaning on this teleclass series. So my goal today is not to review all of the environmental cleaning for hospitals as a whole, but rather I want to present the results of the study we conducted in our hospital, St. Mary's Hospital in Montreal. So if you go to the next slide, I have my disclosures that are stated there, and as you can see, I don't have any conflicts of interest that are relevant to this study. If we move on to the next slide, the learning objectives are to recognize the existence of cleaning gaps and of gray zones in your respective institutions, hopefully to develop an approach to assess the relative risk in terms of transmission that can be posed by gray zones, and finally to integrate transmission patterns and hospital design to inform your environmental cleaning strategy. Next slide. So this is something that you all know. Environmental cleaning is an integral part of infection prevention and control programs. So this particular document is lifted from the WHO Practical Guidelines for Infection Control in Healthcare Facilities, and in which it states, routine cleaning is important to ensure a clean industrial hospital, that any areas that are visibly contaminated with blood or body fluids should be cleaned immediately with detergent and water, and further that isolation rooms should be cleaned with a detergent disinfectant solution at least daily, and horizontal surfaces and all toilet areas should be cleaned daily. The next slide. Again, something that you all are very familiar with is that hospital surfaces are, of course, frequently contaminated with microorganisms that are shed from the patients. And further, if you look at the table on the right-hand side, it lists and this is lifted from several studies, the duration of survival, the length of survival on surfaces, on inanimate surfaces, meaning outside of human hosts, for each particular organisms of interest. So many of the bacterial organisms can actually survive several months up to a year or even longer than a year for many of the bacterial organisms. That being said, the way these organisms will be transmitted from one patient to another is generally through hand contact, not often directly from these surfaces. So if we go to the next slide, and I'm sure you're all familiar with this slide as well, this is the slide, the traditional slide that shows the 4 moments of hand hygiene, but the 5th moment, it has been said, should really be to perform hand hygiene after contact with patient surroundings, be it the bed rail, the light switch, or the telephone. So theoretically, if compliance with these 5 moments was truly perfect and 100%, there should really be very little or no transmission of healthcare-associated pathogens from patient to patient. And it stands to reason that if the microbial burden is high in a patient's environment, meaning a patient is shedding large amounts of organisms, whether it's C. difficile, VRE, or another organism, in his or her environment, then even with appropriate hand hygiene, the roommate or the next patient that would be admitted in that room would potentially be at high risk of acquiring that same organism unless the room has been adequately cleaned. So if we go to the next slide, we're now at slide number 7. On the right side, you see a figure from a study that was published in 2006 showing how increasing the cleaning rate, which is represented by the blue bars, correlates with a decrease in patients' acquisition of VRE, showed by the red lines. However, the exact contribution of environmental cleaning to transmission risk is very difficult for us to assess, and that's because of the many confounders. You know that we do, in infection control, we have a bundle approach to many of the interventions that we do, specifically because it is so hard to isolate one intervention and compare that one to others. So how do we decide in our respective institutions which environmental cleaning strategy to adopt? How do we decide how much environmental cleaning is necessary or required? So if we go on to the next slide, we have some best practices, and this is what many hospitals are already doing or should be doing. The first one is physical removal of dust and organic debris by mopping or rubbing or scrubbing. The second is to disinfect with a hospital-grade disinfectant, oftentimes a quaternary ammonium-based product. And the third one is for select rooms, particularly those that have been occupied by patients carrying VRE or C. difficile, to do a double or terminal cleaning with a sporicidal agent. And finally, all of these steps should be done by very well-trained housekeeping staff. Next slide is what happens actually in real life. In real life, as you probably all know, most hospitals apply their own standards for cleaning, and there's a large amount of variability between hospitals, and within the same hospital, from unit to unit or area to area, there's variability in terms of the available resources. There may or may not be 1, 2, 3 housekeepers available, the frequency of cleaning, the monitoring of the quality of cleaning, whether or not the quality of cleaning is monitored, and if it is monitored, the method of monitoring that's applied will be highly variable. And of course, which surfaces are actually cleaned is hugely variable, ward to ward, hospital to hospital. If we go on to the next slide, this is a slide that shows you the results from a study that was published in 2008, and in which they looked at 23 different hospitals, and they looked at the cleaning of different surfaces, and they assessed the cleaning of different surfaces such as sinks, toilet seats, tray tables, etc. And when they did the comparison across these 23 hospitals, they showed, and that's shown in the middle column that says range, percentage cleaned range, you see that there is a huge variability in the percentage or the proportion of objects cleaned. The bottom right-hand graph shows you the same kind of data, but for the 4 surfaces with the highest cleaning rates, and those were the sinks, the toilet seats, the tray tables, and the bedside table, as well as the 4 that had the lowest cleaning rates, and those were the toilet handhold, the bedpan cleaner, the doorknob, and light switch. So you see a huge variability, a huge degree of variability from hospital to hospital. If we go to the next slide, this illustrates what contributes to this variability. There are actually very few good studies that are conclusive in terms of environmental cleaning and disinfection strategies. So this figure is from a recent systematic review of studies on environmental cleaning and disinfection strategies for hospitals, and that was published in 2015. So on the left-hand side of the figure, you see on the vertical axis, you see the actual strategy. So starting from the bottom, quat-based ammonium detergent, chlorine-based detergents, sporicidal agents, etc. And on the right horizontal axis, you have the number of studies as well as the type of studies assessing each specific strategy. Randomized controlled trials are represented in the darker blue shade. And you can immediately see visually that most of the studies done compare the individual strategy with only historical controls, shown in black, or with non-randomized concurrent controls, showed in the white bars. Very few studies, except for those actually assessing quaternary ammonium detergent, have been assessed in a proper randomized control trial, which is essentially our gold standard for clinical research studies. If you go on to the next slide, you see that there is even fewer well-conducted studies assessing monitoring strategies post-environmental cleaning. So none of them are randomized control trials. The majority are non-randomized concurrent controls. So this actually illustrates why it has been so difficult for most institutions to adopt universal guidelines for cleaning and for monitoring after cleaning. Go on to the next slide. You're all familiar with how items are categorized for cleaning and disinfection in hospitals, and we still use the Spalding classification for items, so critical, semi-critical, and non-critical items. But for environmental surfaces, they're further divided into housekeeping surfaces, and that includes floors, walls, tabletops, bed rails, etc. These can be further subdivided into low touch versus high touch, depending on the frequency with which they are touched or used. And the second type of environmental surface would be medical equipment surfaces, and these are things like knobs on dialysis machines, instrument carts, IV poles, etc. Next slide. Of course, bacteria will not differentiate between a hospital surface and a medical equipment surface. They will potentially contaminate a wide variety of surfaces. So this is a picture of an ICU environment in which a VRE positive patient was admitted, and VRE was recovered from housekeeping surfaces like the table, the commode, the sink, the bed rails, as well as on medical equipment surfaces like the monitor, the patient scale, the IV pole, the various knobs on instruments, etc. This is a picture from an abstract presented at ECAC in 2001 by the author Hayden. So next slide. Our focus here, therefore, is contaminated medical equipment. These can come into contact with a patient directly and serve as a direct source of transmission, or they can come into contact with the healthcare worker's hands, gloved or ungloved, and become, therefore, a source for indirect contamination to the patient. So most of these items are generally non-critical items, meaning they will not go to your CSR unit for disinfection. And in most places, because they are medical equipment, they will not or cannot be cleaned by housekeeping. So next slide. These are the equipments, these are the items that we call the gray zones. The lay dictionary definition of gray zones is that these are areas that are not easily defined and not covered by an existing category or set of rules. So for our purposes, gray zones are surfaces that are not routinely cleaned. It doesn't mean they are never cleaned, just that they are not on anyone's list of tasks for cleaning. And often the specific reason why they are not cleaned is because they are not assigned and often that is because they are used by many different service providers. The specific items that would fall into that category will vary from institution to institution, and sometimes even from unit or ward to ward. If we move on to the next slide, our study hypothesis was that gray zones, particularly those that are high touch, are potentially significant reservoirs of infection. Secondly, we hypothesized that the impact of cleaning these gray zones on actual transmission of hospital-acquired infections should be measurable, and further that the study would actually provide an opportunity to assess the role of environmental cleaning on actual patient outcomes. So next slide, we're now on slide 18. I'm introducing our setting here. St. Mary's Hospital is an acute care hospital with 280 beds situated in Montreal and servicing a diverse population. The hand hygiene compliance rate in our institution is roughly around 60%, and this is based on several audits performed over the years preceding the study, so similar to what is reported widely in the literature. And our nosocomial VRE incidence rates is 3.5 per 1,000 patient days. So note that this is per 1,000 patient days and not per 10,000 patient days, as is often reported in the literature. Our MRSA incidence rate is about half of our VRE incidence rate, 1.8 over 1,000, and our C. diff incidence rate is quite low at 0.8 per 1,000 patient days. So, and most of our transmissions occur on two specific medical wards, which we'll call A and B, while the rest of our hospital, surgery, oncology, and ICU, gynecology, obstetrics, have exceedingly low transmission rates. On our next slide, you have baseline comparisons between the two wards, A and B. So on Ward A, both had similar nurse-patient staffing ratios, but on Ward A had higher capacity with 49 beds. Only about half of the patients were receiving active medical care, where the others were waiting for long-term placement. This is the ward that is part of the original hospital edifice built in 1940, so it's the least modern ward that we have in the hospital. And the majority of the patients housed in that ward are sharing 2, 3, or 4 bedded rooms with 1 bathroom per room, and only 5 single rooms on that ward. There were only 5 single rooms in that ward. Ward B, however, had a lower capacity, so 34 beds. All of the patients receive active medical care, and this is the ward that was built in the more modern extension of the hospital in 1970. And so most of the rooms were either single or double occupancy room, and there were no 3-bedded or 4-bedded rooms on that unit. So patients shared at most their bathroom with 1 other roommate. In all other aspects, whether it's floorings, wall coverings, and furniture, they were similar on Ward A and Ward B, and the same housekeeping staff worked on both units, and the cleaning policies were the same on both. If we go on to the next slide, I'm now moving on to our screening and surveillance policy, so I'm still talking about our study setting. In our hospital, our infection prevention and control policy mandates that any high-risk patient, being admitted, will be screened on admission for MRSA and VRE, our criteria for high risk are patients that have had any previous admission in the last 12 months, or who are employed in a healthcare institution, as well as patients who were deemed to be positive at any time in the past, or were in close contact with a positive case. We additionally performed weekly surveillance screens on each ward, and every patient upon discharge would get also an MRSA or a VRE screen. Finally, for C. difficile, we do not screen, but we test all diarrhea cases for presence of C. difficile. Next slide. Our policy mandates that any patient identified as positive for MRSA, VRE, or C. difficile are placed under isolation or kept in cohorts with others harboring the same organism, and we use contact precautions in all these instances. Hand hygiene measures are facilitated by having hand rubs, antiseptic hand rubs, beside every single room in our institution, and hand washing sinks are available in the hallways in each hallway of the 2 wards that are under study. Next slide. In terms of environmental cleaning, our policy, what we do in our hospital is daily mopping of the hospital surfaces, so the floors in the hallways and in the patient rooms. The bathrooms are cleaned daily with disinfectant, and after discharge of patients, the entire room is thoroughly cleaned and disinfected. We additionally do, as per the best practices, double cleaning using a bleach-based product of rooms that were occupied by VRE or C. difficile positive patients after their discharge. However, as in many other institutions, we did have several patient care items that were not assigned to housekeeping, so for which cleaning was probably not consistently done. So what we did is we first, at the start of the study, we first listed the items that would potentially fall under the gray zones category, and this is shown on slide number 23 in the left-hand table. You have a list of our gray zone items. So these are items like laundry hampers, portable blood pressure machines, rolling walkers, scales, patient lifts, footstools, etc. And our intervention was first to assign a trained housekeeper for specific cleaning of these items. So we obtained authorization from our senior administration to assign one housekeeper to exclusively and only clean those items, and so he was released from his other duties. We established a cleaning frequency for each of these items, and then we subsequently we monitored the efficacy of cleaning, and I'll go into detail on that on the next slide. And finally, we decided that we were going to measure outcomes, so the transmission rates. And our outcome was going to be patient transmission rates to enable an actual cost-effectiveness analysis. If we go on to the next slide, we have divided our gray zone items listed in the previous page into high and low touch based on their frequency of use. And the items that we consider to be high touch, we decided were going to be cleaned daily between patients, and those that were low touch items were going to be cleaned weekly. And so that's specified in the table presented in this page. Next slide. The method of cleaning was also protocolized and established ahead of time. So each item was going to be cleaned was going to be first wiped with a wet rag that had been soaked in a solution containing soap and water, and this was the removing organic debris and dust part of our cleaning protocol. Second step was going to be disinfected using our hospital quat-based product, and that was going to be either sprayed or applied with a cloth depending on the item and left on for 10 minutes. And again, as I mentioned earlier, the entire study was going to use one dedicated gray zone cleaner who was going to work Monday to Friday from 8 to 4 p.m., and there was no gray zone cleaner during the weekends or at nights or on holidays. Next slide. So we adopted a crossover design to be conducted over 1 year for our study, meaning Ward A, that's represented on the Ward A, would have the intervention during period 1, and the intervention was standard routine environmental cleaning as we have always done, with gray zone cleaning. So it's basically enhanced cleaning during period 1, and that was going to be the intervention period for Ward A. During that time, Ward B would have the routine standard cleaning, so that was the control period for Ward B. And in period 2, which was of equal duration as period 1, Ward A would have the reverse. So the control period, meaning only regular cleaning would be done during period 2, and for Ward B, routine cleaning plus gray zones cleaning would happen during period 2. We also ensured that for monitoring, we had the head nurses of each ward doing spot visual checks of the quality of environmental and gray zone cleaning. And we tested, additionally, microbiologically tested for growth of MRSA and VRE from random samples of 15 gray zone surfaces per week. And these, because they were to monitor the quality of cleaning, were only done after cleaning, and they were done by the infection control nurses, not by the housekeeping staff that was engaged to clean those gray zones. Next slide. I'll first start with giving you the results of the monitoring of the quality of gray zone cleaning. So in total, over 1,500 swabs that were covering 108 surfaces of different items were tested for growth of VRE and MRSA after cleaning. And in total, we only had 3 swabs that were positive for growth after cleaning. 1 was positive for VRE, and 2 were positive for MRSA after cleaning. So in total, 3 out of 1,556. So it's in the range of 0.2%. So we concluded that 99.8% of our surfaces had no growth after cleaning, meaning our gray zone surfaces were adequately cleaned and had a very low microbial burden. Next slide. Before showing you the actual impact of cleaning the gray zones, we wanted to make sure the patient populations were comparable between the 2 periods, meaning between the intervention period and the control period. And indeed, for each ward, the populations admitted were similar in terms of age, in terms of sex, comorbidity scores, and their length of stay. So it's unlikely that a significant bias could be introduced just by the fact that we were looking at 2 different periods of time. However, between Ward A and Ward B, the patient populations were slightly different. Ward A had, on average, older patients, stayed longer in hospital, and of course, as expected, since they are mostly 2, 3, and 4 bedded rooms, patients had a greater number of roommates each. So this is just to show you why it was important to only compare Ward A to itself, the control period with the intervention period, and Ward B to itself, but we did not compare Ward A versus Ward B in terms of the other outcomes. Next slide. This is a bit of a busy slide, and it's in essence it's the table that shows our findings. If you look at the bolded values are the ones indicating a statistically significant difference between the intervention period, where the gray zones were cleaned in addition to the standard cleaning, and the control period. So you see that these statistically significant differences were only shown for Ward B and for VRE transmission. So if you look at the specific numbers, under Ward B, vancomycin-resistant enterococcus, you see that during the control period, there were 33 transmissions, 33 VRE transmissions, and that number went down to, there were only 17 transmissions during the intervention period, a difference that was a 2-fold decrease that was statistically significant with a p-value of 0.029. And this difference remains statistically significant after adjusting for potential confounders in the multivariate analysis. If you look at the number of C. diff cases during the control period, there were 10 nosocomial C. diff cases in the control period, and during the intervention period there were only 5 C. difficile cases. But that difference, that drop, although it looked like a 2-fold decrease, it did not reach statistical significance, presumably because the numbers were very small. The number of MRSA transmissions stayed the same between the 2 periods. Next slide. This basically shows this basically summarizes the findings shown in the previous table. So overall, we had lower transmission rates during the intervention compared with the control period on Ward B, but we did not see that on Ward A. VRE transmission was most significantly impacted, with an incidence rate dropping from 6.2 to 3.2 patient to 3.2, and that was a twofold decrease with a significant p-value. There was a small decrease in C. difficile transmission rates, but that was not statistically significant, and MRSA transmission rates were unchanged. Next slide. This is the slide that shows you the patterns of transmission on Ward A. Remember, Ward A is the ward that has the most patients sharing 2, 3, 4 bedded rooms and sharing 1 bathroom per room. So if you look at the gray shaded area, that was the intervention period. You see there was a cluster of 11 cases in a relatively short period of just a few weeks during that period of time. And during the control period, which is represented in the striped area, you also see another peak, though this one is a bit of a flatter top, but many cases occurred over a relatively short period of time. If you go on to the next slide, this is a transmission patterns shown for Ward B. So this is a ward with most patients either in a single room or in a double-bedded room. So during the control period, which is shown in the striped area, they had ongoing transmissions gradually increasing over the 6 months of the control period. So in total, 33 cases, but increasing. As soon as the intervention started, within the first 2 weeks, the number of VRE transmissions abruptly dropped within the first 2 weeks and stayed low all the way through to the end of the intervention period. And as soon as the intervention was lifted and the study ended, the transmission rates went right back up and continued to increase. So I have put in the box there that there were more than 34 VRE transmissions over the subsequent 6 months. Next slide. So to summarize, on Ward A, we had peaks of VRE transmission, with the majority of cases occurring in a short time span, and that was a pattern that's consistent with a focal outbreak, whereas on Ward B, we had fairly constant VRE transmissions over long periods of time, over months, consistent with endemic transmission. For MRSA and C. difficile, we had low-level and constant transmission throughout the study. So next slide, we're now on slide 34. We can conclude from this that we had the effect of the gray zone cleaning was a twofold decrease in VRE transmissions on the ward where transmission followed an endemic pattern. And as a reminder, this is the ward with patients where patients had fewer roommates and private bathrooms, but they were more acutely ill. And in fact, it is the ward which in our hospital has the absolute highest burden of VRE transmissions. Our gray zones cleaning intervention had no significant impact on the ward where transmissions of VRE is clustered, where index patients tend to have more roommates and share bathrooms, but where transmissions are rapidly controlled with cohorting and with patient discharges. Next slide. We also conclude that specific targeted gray zone cleaning had no impact on MRSA in our study. Our baseline rates for MRSA are already very low in our institution, and they are decreasing elsewhere in Canada too. So it's very difficult for us to know whether our low rates are because of something we are doing. Is it because of our environmental cleaning strategies and our hand hygiene compliance rates, or is it just a natural phenomenon of clones disappearing throughout the world? That remains to be elucidated. There is one study that was conducted in the UK where they did enhanced cleaning of their ICU, and in their ICU, MRSA is the predominant organism of concern. What they showed was that they were able to achieve a substantial reduction in recovery of MRSA from their surfaces near patients. However, they showed no impact on patients' acquisition of MRSA. Next slide. This is another study also performed in the UK, which showed again a reduction in colony counts that was shown in the y-axis, meaning colony counts from surfaces after enhanced cleaning with also an extra worker, with an extra housekeeper, and they showed a suggestion of a reduction in healthcare-associated MRSA, but that did not reach statistical significance. Next slide. So in our conclusion, therefore, is that when the infrastructure of an institution is favorable, an infection prevention and control program is functional and in place, meaning with screening strategies, surveillance strategies, isolation and cohorting, shared patient care items that are considered gray zones are definitively potential discrete reservoirs of infection, and that targeting these items through specific cleaning can be cost-effective. We know from previous estimates that VRE increases the cost of hospitalization by about 18,000 Canadian dollars. At least these are studies from Canada. We also know, at least in Quebec, that the average salary of a housekeeper is around $35,000 per year. So we estimate that if we can decrease VRE transmissions by even 2 cases per year, we've paid for our housekeeper. As I mentioned earlier, our Ward B has usually over 60 transmissions of VRE per year. So if we are able to reduce that number down to 30 transmissions per year, we would have saved our hospital somewhere around $500,000. If we go to the next slide, we are now at very near the end. Our take-home messages here obviously are that environmental cleaning, as you all know, is critical for reducing healthcare-associated infections. However, there aren't a lot of studies that are well-conducted randomized control trials to directly assess the impact of different strategies, cleaning and disinfection strategies, on patient outcomes. We suggest, however, that there are practical approaches that is based on looking at the pattern of transmission in specific units of the institution in which you work. If you deem that you have more of an endemic, sustained pattern of transmission, and that this occurs despite multi-component infection prevention strategies that are already in place, that should prompt consideration of targeted extra cleaning of clinical care items that are non-critical but high touch. And finally, another conclusion, our final conclusion, is that a crossover design is a reasonable alternative to randomized control trials for environmental cleaning studies and to demonstrate impact and cost-benefit analysis. I will leave it there. I have left you some references on slide 39, but I will thank you all for your very much for your attention, and feel free to email me any questions that you might have or any comments that you might have. Thank you very much, and I'll leave it back, and I'm handing it back to Paul.
Thank you very much, Dr. Sermet. I was struck in your last slide there, particularly I think on slide number 37, where you speak of the value and what you would be saving at hospital. It's a terrible shame that we never know what we prevent. It's hard to show a case for that to hospital administrators and the people who hold the purse strings, because it's hard to show a direct line of cause there, isn't it?
It is, absolutely. I mean, despite the fact that this was done, this was done 2 or 3 years ago, or more than 3 years ago now, and presented formally in several venues, I think our hospital administrators are still doubtful, and certainly hiring more people is generally not the kind of solution that they are looking for. So, it has led to us evaluating different strategies to include gray zone cleaning. So we're now actually conducting, we've just finished conducting a study on looking at the UV, DI types of strategies to include, in which you could leave the machine in the room and leave the gray zones in the room and still not use a human being to physically, spend all that time. So, but you're right that it's very hard to convince an administration, even when you have these numbers to support it, that the solution might be in having more people to clean.
Yeah, so a janitor isn't quite as attractive, perhaps, as a new piece of equipment. It's hard to raise funds for a janitor.
Exactly.
And I noticed you indicated in your study that you really didn't reduce MRSA transmission to a great extent. I've seen this in a lot of other articles as well. You pointed out a couple of them. Should we consider MRSA as part of a normal environmental flora in hospitals now and not get too concerned about it?
I wouldn't say we wouldn't get too concerned about it, but my assumption, and I think it kind of makes biological sense, is that I think MRSA is probably predominantly transmitted, just through hand contact. It is an organism that lives in the nose and that's on our skin. So probably good compliance with hand hygiene and the basic things that we already do are probably sufficient to limit MRSA transmission. Whereas VRE is a little bit more hardy and probably does live in these reservoirs, in these hidden reservoirs and on contaminated objects. And it probably takes a smaller burden of VRE to colonize the next patient. So I think VRE ends up being more of our environmentally tough one, and MRSA is probably reasonably well controlled with hand hygiene. Right. That's the way I've kind of interpreted those numbers.
Well, that's a fair comment. Before I close, I wanted to encourage the audience to look up an article called "A Magician's Tale." It was published within the last couple of years by our speaker today, and it's an interesting read. Of course, it has one of the most compelling titles for an academic article that I've seen, and it's just inviting you to read it. But it's a tale of a young man who goes to a healthcare. Well, actually, I shouldn't describe. Dr. Semrat.
It's a case report.
Yeah.
It's a case report. Yeah, it was an interesting case.
It's a very interesting case, and you have to read it if just because the title is so compelling.
Thank you.
On slide 41, Dr. Semrat very generously left her email address, which invites you to contact her if you have questions regarding this paper and this lecture. On the next slide, number 42, these are the balance of the teleclass topics that are pending for this year. The next one, which is actually, I might have those reversed. Yes, I guess on Monday, in fact, is a lecture being broadcast live from the Australian conference, the Australian College of Infection Prevention and Control. That will include, well, there's just 3 lectures. In fact, there are 4 people listed there, but one of them isn't letting their lecture be broadcast. So there will be 3 of those lectures broadcast as live teleclasses. And then on Tuesday in our European series, Dr. Hilary Humphreys will speak on the role of rapid diagnostics in healthcare infection. And then in December, beyond high-touch surfaces, something that relates, I think, to this talk very well. That's Curtis Donsky from Cleveland. And then we're rounding up the year with Dr. Hugo Sachs and Dr. Andrew Stewartson of Zurich, and I'm not sure where Dr. Stewartson is. He's in Australia. But that's on enhanced performance feedback and patient participation to improve hand hygiene compliance. I hope you will join one or more of those. On the very last slide, it indicates our patron sponsors, and I'd like to express my appreciation again to these organizations, the World Health Organization and Virox and Sealed Air Diversity Care, for their generous and ongoing support. To all of you, thank you for joining us today. Dr. Semrat, that was a very interesting talk, and you can expect an invitation perhaps in the next few minutes to come back and speak to us again next year regarding your work in Ethiopia. I hope you'll say yes.
Thank you. Okay.
We'll talk to you all again very soon. Goodbye.